Bismillahirrahmanirrahim. Today the topic under discussion would be shoulder dystocia. It is Green Top guideline number 42. It is one of the important guidelines for your MCQs, for the clinicals, as well as for your daily routine practice. So let's start this guideline. And one thing I want to tell you that we have different books, local books available, in which different types of definitions are given. But if you extract the definitions from this guideline, then this will make you different from the rest of the candidates during your clinicals, and it also gives very good impression. Like shoulder dystocia, you have to memorize it like this, that it is defined as the vaginal cephalic delivery that required the additional obstetrical maneuvers to deliver the fetus after the head has delivered and the genital traction has failed, and the prolongation of the time, that is head to the body delivery time, more than 60 seconds. Girls, please bear with me. I have a severe throat infection. So if there is some disturbance in the voice, then please bear with me. We have two types of shoulder dystocia. This was the exam question asked from one of the exam candidates in clinicals, and she was blank there. Because when someone asks you directly the types of shoulder dystocia, then you start thinking about that what are the types. But the types are either anterior shoulder is impacted, or either the posterior shoulder behind the symphysis pubis and sacral promontory respectively. But sometimes we can have both the shoulders impacted. Incidence is important for exam perspective, 0.5 to 0.7. Now the complications: severe paternal morbidity and mortality with this shoulder dystocia. How to memorize this? This is PPH. In H we write like this. So these two strands of the H is 11%. Then the third and the 4th degree tear. Third and 4th. If you double the 4, it becomes 8. So it is 3.8%. Brachial plexus injury is 16%. How you will memorize this? B has two loops. Okay? B has these two loops. So 2%. And look at this I. I means 1. And this P, if you invert the P, it becomes 6. Okay? So 2.3 to 16%. If you memorize like this, you will never forget these percentages. Okay? Let me repeat again. PPH is 11%. Third and 4th degree tear is 3.8%. And then the brachial plexus injury is 2.3 to 16%. All these are MCQs. This is one of the MCQ of past MRCOG, that how much is the permanent neurological dysfunction. It is 90%. So means 10%. So means 90% will have no permanent. They can make an MCQ like this. 90% will have no permanent neurological dysfunction and 10% will have. Okay. Now the infant's larger infant means the weight is more, then the chance of shoulder dystocia is high. Now sometimes this is also very important. 46%, this is important for your clinical point. When you are practicing in your clinics, so this is important. We should be safe doctors. 46% of the injuries are due to substandard care. So not all injuries are due to excessive traction by the healthcare professionals. Some of the injuries can be due to the maternal propulsive force. When the mother is contracting, some of the injuries are due to that propulsive force, but 46% are due to substandard care. So what does this mean? Okay. One other thing, when the posterior shoulder is involved, when the posterior plexus, part of the brachial plexus is involved, it is unlikely due to the action by the healthcare profession. Okay, it is not due to your traction. Okay, it must be due to mother pushing or something like that. Now these were the basics of this guideline. Now how can we predict the shoulder dystocia? We have certain risk factors for these women, but the risk factors can never predict the shoulder dystocia, so they are insufficient for predicting. This is an important question, that infants of the diabetic mother have 2 to 4-fold increased risk of shoulder dystocia. The other thing is, this point was important because for the clinical candidates, I I want to tell you the thing that this gynae and obs is interrelated. ठीक है? So whenever you get the knowledge from one place, you have to apply it to the other. Now here it is clearly written that the clinical fetal weight estimation is unreliable. जिस तरह हम estimated fetal weight करते हैं वो unreliable है, और जो scan है उसमें भी at least 10% margin of error है from actual birth weight. ठीक है? और sensitivity is just 60% for macrosomia over 4.5 kg. अगर क्लिनिकल एग्ज़ाम के दौरान भी कभी आप एस्टिमेटेड फीटल वेट बता दें एग्जामिनर को और वो कहे कि इसमें डिफरेंस आया है, यू कैन क्लियरली से मैम द क्लिनिकल एस्टिमेशन इज़ अनरिलायबल. और अगर कोई अल्ट्रासाउंड पे आपको कोई वेट का डिफरेंस या कुछ इस तरह क्लिनिकल सिनारियोज़ में कोई इशू आता है, आपने एग्जामिनर्स को अपने आप को जस्टिफाई करना होता है ना. सो यू कैन टॉक टू योर एग्जामिनर, मैम I cannot, if you don't want to, this I am telling for the clinical candidates. ठीक है? ये अगर आपको लगता है कि उसका वेट आपको 3.8 दिया हुआ है या 4 दिया हुआ है, लेट्स सपोज 4.5 दिया हुआ है, और आप उधर क्लिनिकल केस में डिस्कशन करें एग्जामिनर के साथ कि आई वांट टू गो फॉर सिजेरियन सेक्शन, ठीक है, तो वो आपको कहेगी कि नहीं वेट तो इतना है, आप फिर अपने आप को उधर जस्टिफाई कर सकते हैं कि 10% एक्चुअल एरर तो होता है, क्या पता ये ज़्यादा हो, ये 5 kg हो, सो आई कैन नॉट जस्ट टेक अ चांस इफ़ द वुमन हैज़ अदर रिस्क फैक्टर्स एज वेल. ठीक है, तो दिस पॉइंट इज़ वेरी इंपॉर्टेंट फॉर योर क्लिनिकल एग्जाम. The other risk factor associated with the shoulder dystocia are pre-labor and the intrapartum. The pre-labor one are the previous shoulder dystocia, macrosomia more than 4.5, diabetes, BMI more than 30, maternal, induction of labor. इसको याद करने का तरीका है prolonged first stage, prolonged second stage, prolonged second stage, secondary arrest, then oxytocin augmentation, and then instrumental delivery. So you have to, if you want to memorize these 5s on your fingertips, then prolonged first stage, prolonged second, secondary arrest, oxytocin, and instrumental vaginal delivery. Okay. So here are the few points I want to talk about the management of suspected fetal macrosomia. So induction of labor, these are very important for your MCQ. If the woman is non-diabetic, if you do induction of labor for them, it is not a prevention of shoulder dystocia. But if you have induction of labor for a patient with GTM, it decreases the risk of shoulder dystocia. Cesarean section for women with GTM or with type 1 or type 2 diabetes mellitus, you will go for cesarean section when the estimated fetal weight is more than 4.5 kg. When the estimated fetal weight is more than 5 kg, then you can go for cesarean for a normal woman as well. That is that she is not diabetic. Okay, I hope this is clear. I want to repeat it again. Induction of labor for the prevention of shoulder dystocia in non-diabetic women has no role. For gestational diabetes, induction at term decreases the risk of shoulder dystocia. Cesarean section for women with diabetes and the estimated fetal weight more than 4.5 kg, you should do cesarean for that. Okay. Now, this all I highlighted, I have written it above. This point I also explained to you that cesarean section elective should be considered with a woman with pre-existing diabetes or gestational diabetes when the weight is more than 4.5 kg. Why just for the diabetic? Why not for the non-diabetic? In diabetics, when 443 cesareans are performed, you prevent one permanent brachial plexus injury. But in non-diabetic, when you perform 3695 cesarean, so cesarean is also a kind of morbidity you are giving to your patient. So for performing that much of cesarean sections to prevent one permanent, it is not justifiable. So just for the women with diabetes, you go for cesarean section. And this we talked about already. Now coming towards the recurrence. This is also an MCQ of the mastering. 10 times recurrence and 1 to 25%. 10-fold in folds recurrence, and in percentage it is 1 to 25%. Okay. Now management of shoulder dystocia. This is very important. Okay, for the IMM, for the clinicals, and for you as well. So prompt recognition, rest of the candidates will not do the prompt recognition in this way, but you have to say that when I observe the difficult delivery of face and chin, when the head remains tightly applied to the vulva, turtleneck sign, failure of restitution and failure of shoulder to descend. Routine axial traction should be used, but all other tractions should be avoided. We will come towards this routine traction. Routine traction is the traction that is required for the delivery of the shoulder in the normal vaginal delivery, where there is no difficulty with the shoulders. Axial traction is in line with the fetal spine. Whenever you apply routine traction and in line with the axial spine, it is the normal traction. But when you do downward or lateral traction or rapidly applied traction, it causes nerve avulsion. We have seen in our daily practice that majority of the shoulder dystocia babies are delivered by downward traction or lateral traction. This is a very wrong approach. You will not apply downward traction or the lateral traction now onwards, because this causes the nerve avulsion and it causes, so this should be avoided because it leads to the brachial plexus injury. Okay, now the prophylactic, give importance to each and every word in your MCQ scenario and in each and everything. If the word prophylactic is given in the MCQ, then there is no need of the macrobid positioning, because it is not recommended for the prophylaxis that for the prevention of the shoulder dystocia you put the mother in the macrobid position before the shoulder dystocia. Okay, so the macrobid has no role in the prophylaxis. Once the shoulder dystocia is developed, then the macrobids has. Now once the shoulder dystocia occurred, you have to call for help. First, you have to clearly state to the team that the shoulder dystocia has occurred. Second, no fundal pressure, because fundal pressure will lead to uterine rupture. Ask the mother stop pushing, because it will further impact the shoulder. Okay, first one is the macrobid maneuver. It is the simple, rapid, effective and should be performed first. The second one is suprapubic pressure, and episiotomy is not always necessary. Maternal pushing should be discouraged. Fundal pressure should be discouraged. Macrobid. What is macrobid? This is important for MCQs, all these points. When they ask about macrobid, it is the flexion and abduction of the maternal hips. Flexion and abduction of the maternal hips. Maternal thighs on her abdomen. It straightens the lumbosacral angle. It increases the AP diameter of the pelvis. The success rate is 90%. When they ask about the maneuver with the low rate of complication, the least invasive maneuver, and the what should be employed first, it is macrobids. Okay. Now when the macrobid is not successful, the second is the suprapubic pressure. This suprapubic pressure is also called Rubin 1. Okay. It is just exactly like the Rubin's 2. But Rubin's 2 is an internal maneuver that we perform within the vagina. Internal maneuver. And the Rubin 1 is when we apply the pressure or traction on the posterior aspect of the anterior shoulder. When you apply it from the abdomen, like this is the anterior shoulder, upper shoulder of the baby, and you apply traction on the posterior aspect of the anterior shoulder, but from within the maternal abdomen, above the maternal abdomen, not within, above the maternal, it is Rubin 1. But when you insert your fingers into vagina and you apply traction on the posterior aspect of the anterior shoulder, it is Rubin 2, because you are applying pressure within the vagina. Okay? Now what is the purpose or significance of this suprapubic pressure? It decreases the biacromial diameters, and this helps the shoulder to slip underneath the symphysis pubis with the aid of routine axial traction. So the posterior aspect of the anterior shoulder, you apply the pressure. Whether you apply in a continuous manner or a rocking manner, there is no clear difference between the two. So this is also an important MCQ, that episiotomy will not relieve any bony obstruction. It will just facilitate the internal maneuvers. And the episiotomy does not decrease the risk of brachial plexus injury. Okay, now if all the simple techniques, that are the MRCOG and the suprapubic fail, then you will go towards the internal maneuvers or the all fours. So for the internal maneuvers, you have to approach the most spacious part of the vagina, that is the sacral hollow, and posteriorly you have to insert your fingers. Now here internal maneuvers we have three types: Rubin 2, wood screw, and reverse wood screw. As we already discussed that, let's suppose this is the upper or the anterior shoulder of the baby, and this is the maternal abdomen. When you were applying the pressure on the posterior aspect of the anterior shoulder from the abdomen, it was Rubens 1. But when you similarly apply the pressure on the posterior aspect of the anterior shoulder, it is Rubin 2 from within the vagina. Now keeping the same fingers on the anterior aspect, on the posterior aspect of the anterior shoulder. Okay, here what are you, let me change the color so it is easy for you. This is the anterior shoulder. Okay, and the pressure we will take as blue color. This is the anterior shoulder, and you are applying traction on the posterior aspect. Okay, you are applying pressure on the posterior aspect. This is what maneuver? This is Rubens 2. Now here you can see the shoulder is anterior, the pressure you are applying is posterior. Now if this fails, then keeping your same hand here, like on the anterior shoulder, its posterior aspect, you have to keep the finger. Now again this is the posterior shoulder. Okay, and the traction you are applying is on the anterior aspect, and you try to rotate the baby. Okay, this is the wood screw. Look, posterior aspect of anterior and anterior aspect of posterior shoulder, this is wood screw. But if you apply the pressure on the posterior aspect of the posterior shoulder, it is reverse wood screw. These are the three internal maneuvers. Okay, one is the delivery of the posterior arm. Sometimes you can, the delivery of the posterior arm is very simple. You have to hold the fetal wrist and grasp it, the posterior arm gently withdrawn from the vagina in a straight line. Okay, with the posterior arm we have humeral fractures. ठीक है, आप हैंड को मैनिपुलेट कर रहे हैं तो 2 to 12%. We have 2 humerus 2 and then double 2 to 12. ठीक है. Now sometimes they say whether we have to go for the posterior arm delivery or the internal maneuvers. When the mother BMI is large and both the things are given in the option, then you have to favor the delivery of the posterior arm. Okay, the all four success rate is 83%. Now the third line maneuvers are the destructive maneuvers. You have to deliver the baby within up to 5 minutes. Before going towards the destructive maneuver, usually the hypoxic ischemic injury occurred after 5 minutes. It is very severe, but you have the time up to 5 minutes, because up to 5 minutes there is very low rate of the hypoxic ischemic injury. Okay, the third line maneuvers we have clerotomy, surgical division of or bending with a finger, clavicle, anterior fiber of the symphysial ligament, symphysiotomy, and Zavanelli maneuver. Okay, Zavanelli maneuver is the vaginal replacement of the head and delivery by the cesarean, and it is for the bilateral shoulder dystocia. Okay, posterior axillary sling was used, but the data available are very less. We talked about the possibility of PPH 11%, perineal tear 3.8%, but for the clinical candidates you can add that ma'am, she can have vaginal laceration, cervical tears, bladder rupture, uterine rupture, symphysial suppression, sacroiliac joint dislocation, and lateral femoral cutaneous nephropathy. The baby should be examined by the clinicians. At least annual training should be given to the people managing the woman in the labor ward, and then complete documentation is very important. Okay, now coming towards this flow chart. This is the McRoberts minion. This is the suprapubic pressure. This is the delivery of the posterior arm. First, you have to discourage pushing, lie flat, buttock to the edge of the bed. Now call for help, coordinator, midwife, experienced obstetrician, neonatal team, and anesthetist. First is McRobert, 90% success. Second is suprapubic and routine axial traction. Consider episiotomy, delivery of the posterior arm with mother with a high BMI. Rest of the women you have to go for internal manures. Okay. Now consultant, obstetrician, and anesthetist you have to inform. If above manures fail to release impacted shoulder, consider all fours. It is 83% success. The destructive manures are cladotomy, Zavanelli, and symphysiotomy. Okay, this is very important for the clinical candidates. So how you will discuss about this shoulder dystocia? You can get a scenario about the documentation as well. So the mother name, date of birth, hospital number, and consultant, completing form, date, time, and signature. What is important? Call for help. At what time it was called for help? You can actually get these types of performers in your audits and risk management cases. Okay, so the staff present at the time of delivery, name and their role, additional staff called. अब आपने जो I'm explaining this performer just for the clinical candidates because they can get this performer in their exam, और उनके पास ये performer नहीं होगा, but they have to point out the mistakes in the sequence of events or something like that. तो फिर आपको उस टाइम पता होना चाहिए. मैम, I want to know the person present at the delivery who were called during the emergency, what was their role, at what time they arrived. ठीक है, what procedures were carried out like McRoberts, suprapubic episiotomy, all these manures. Okay, by whom, time, order, details, because in 30 seconds we move to the next manure. ठीक है. Mode of delivery was then spontaneous or instrumental. Delivery time of the baby from head to toe, fetal position, birth weight, cord gases, explanation to the parents, given neonatologist called or not, and then the baby assessment after birth, arm weakness, potential bony fracture और neonatal ICU admit. ये आपने सारा ये परफॉर्मर पढ़ लेना है. ठीक है. This is very important. I hope now the shoulder dystocia is very easy for you and you have remembered all the percentages. When you close this lecture, more than 70% should be in your mind and you should be able to recall all these information. Thank you for attending the class.